Okay, so let's start. Today we have another lecture, and it will be dedicated to the operations on the blood vessels. So first of all, we have already begun to study topographic anatomy, yes, and we know that nearly in every topographical region, there is a neurovascular bundle. In some regions, they are, some people cannot hear me. Well, try to renew the page, maybe. Okay. So in some regions, there are even several neurovascular bundles. So what is it? Neurovascular bundle is a set of a main artery, one or two accompanying veins, lymphatic vessels, and nerve that are surrounded by common facial sheath and blood supply, venous drainage, and nerve supply. As a rule, so yes, they are surrounded by common facial sheath, and they blood supply, collect venous blood, and nerve supply, as a rule, the same region or organ. And so, yes, they are interconnected, these elements inside the neurovascular bundle. So connection between the elements of the bundle is provided by small vessels and nerve branches. Vasa vasorum, if you still remember Latin, yes, vasa vasorum means vessels of vessels. Vasa nervorum, vessels of nerves. Nervi nervorum, and nervi vasorum. So certainly when we studied anatomy, we said that each structure has a blood supply and nerve supply, and certainly vessels and nerves also have blood supply and nerve supply, and so they are supplied by each other, by the branches inside within one neurovascular bundle. This is neurovascular bundle. So they are surrounded by common facial sheath, and Nikolai Ivanovich Pirogov, the great Russian surgeon, the founder of topographic anatomy, he called this facial sheath as vascular sheath. So principles of formation of vascular facial sheath according to Nikolai Ivanovich Pirogov. You have to know it. First of all, vascular sheath is formed by muscular fascia. Vascular sheath has a shape of trihedral prism, triangular in the transverse section. Internal side of the prismatic sheath is connected with adjacent bone or joint capsule. So these are three main principles of formation of vascular facial sheath, and we will see it everywhere in every region. So one of the important characteristics of neurovascular bundle that allows surgeon to manipulate on its elements, it is its projectional line, and we also have already begun to talk about it. So projectional line is a line that passes on the skin on the base of external landmarks, corresponds to the course of neurovascular bundle, and travels maximally close to it. So here, the green line in this picture, it is projection line of this neurovascular bundle. So we said that if we dissect along the projection line the skin, and then we will go deeper and deeper, we will finally reach neurovascular bundle. And it will be the nearest way to the this neurovascular bundle. Okay. Surgical approach or surgical access to the vessels, not only to the vessels, but to all the structures of neurovascular bundle, it can be direct and indirect. So direct surgical approach is that one that corresponds to the projectional line. And indirect, it goes away, stepping back 1 or 2 centimeters from the projectional line. We use indirect surgical approach in case of superficial or vice versa very deep location of neurovascular bundle to avoid injury of the vessel or muscle correspondingly. So look, if vessels are located very superficially, then if we dissect along the projectional line, we can accidentally damage this vessel. Yes, that's why we go away a little bit. If neurovascular bundle is located very deeply, like in case of neurovascular bundle of posterior region of the upper arm, when structures pass inside the humeral muscular canal, we also go away closer to the intermuscular sept, because if we go along the projectional line, then we will reach triceps brachii muscle, and we will have to dissect it. And if we dissect it, then extension in the elbow joint and in the shoulder joint, it will be impaired. Yes, so that's why in these cases we also use indirect approach. So here you can see that this projectional line of the axillary artery, yes, of the axillary neurovascular bundle, and then it continues to the approach, projectional line of the brachial neurovascular bundle. And actually we use the same approach to reach deep brachial artery and radial nerve, because to reach deep brachial artery and radial nerve, we use indirect approach. That's what you can see in this diagram. So which surgical interventions on the blood vessels are distinguished? There are many of them. Mainly they are divided into 6 groups. So these are surgeries at the vascular injuries. These are usually urgent surgeries, yes, emergency surgeries, according to the classification which we had at the previous lesson. Surgeries at the vascular obstruction, it also usually emergency. Then surgeries at aneurysm, it can be pre-planned, and surgeries at the anomalies of vessels development, surgeries at varicose veins, and surgeries at non-vascular pathology. Sometimes we perform surgeries in the vessels when there is not vascular pathology, and we will also talk about it later. Okay, so what are they? Common surgeries on blood vessels. So first of all, it is ligation of the vessel along its course. It is application of ligatures onto the preliminary exposed blood vessel to block blood flow in it. Vascular suture, method of restoration of integrity of the blood vessel by sutures. Embolectomy, it is isolated extraction of the embolus from the blood vessel. Resection of the vessel, removal of the part, yes, like any resection. Angioplasty, restoration of the blood vessel by means of replacement of its defect by vascular transplant. Prosthetics of the vessel, replacement of the circular defect of blood vessel by vascular prosthesis. Vascular bypass, creation of the collateral way of circulation in case of an obstruction of the part of large vessel. Intervascular anastomosis, connection of 2 vessels with each other. So we will try to discuss all of them today, one by one. Okay, so surgeries at the vascular injuries. So in case of bleedings, yes, or hemorrhages. So first of all, we have to know the source of bleeding. Yes, according to the source of bleeding, all of them are divided into arterial, venous, arteriovenous, and capillary or parenchymus. And so methods of bleeding arrest will be different depending on the source of bleeding. According to the direction of blood escaping, means where blood outflows when it leaves bloodstream in case of bleeding. It can be external, when it goes outside of human body and we can see it, yes, like we can see blood outside, and internal, when blood flows to the cavities. And in this case, we do not see bleeding, we just see the symptoms of internal bleeding, that person like depression of blood pressure, weakness, dizziness, finally a person falls unconscious, yes, and so on. And so certainly internal bleeding is much more complicated for diagnostics. According to the time of origin, bleedings are divided into primary and secondary. Primary bleedings, they appear right after the injury, right after any influence. Yes, so like there was an injury and the bleeding started. Secondary, it's that bleeding that appeared sometime after, a short time, maybe long time after the influence, after the intervention. For example, post-operational bleeding, when especially we use coagulation, like energy. Yes, we coagulate something, and first everything is okay, but with the time, bleeding started. Yes, so primary and secondary. And methods of bleeding arrest or bleeding control or hemostasis, like methods to stop bleeding, they are divided into temporary and final. Temporary and final. So temporary are those which we can use, yes, we can use outside of the hospital. Some we use during operation. Yes, it is finger compression. Just you see the bleeding, you put your finger or the hand or anything, compress the vessel, and bleeding stop just for the time. Application of tourniquet. Yes, it's one of the methods of temporary bleeding arrest. Application of the clamp to the bleeding vessel during operation usually, yes. And there are final methods of bleeding arrest or definitive methods. It is ligation of the vessel in the wound, if we can find it in the wound, if it is not such a crushed wound, yes. Ligation of the vessel with stitching. Ligation of the vessel in the wound is just when we ligate it, and that is all. Ligation of the vessel with stitching is when we ligated the vessel and then we restored the integrity of the vessel, and so everything is fine. Then ligation of the vessel along its course, somewhere away, somewhere, if it is artery, somewhere proximally, yes, and if it is a vein, somewhere distally. If we cannot find the vessel in the wound, cauterization. No, it is application of the energy to burn tissues, yes, and to stop bleeding by this way, and application of vascular suture. So these are, so ligation of the vessel with stitching, it's when we do not just tie a knot along the around the vessel, but we also make a stitch through the lumen of the vessel. That is like more reliable, more secure method of final hemostasis. So these are methods of final hemostasis. So also the other classification of methods of final bleeding arrest, it can be mechanical. This is a ligation, suturing, all of these are mechanical methods. Then physical methods, it's usually applied certainly in capillary bleeding. It's hot saline solution we can use to spasm vessels, yes, electrocauterization method, etc. Then chemical methods, we can use hydrogen peroxide, yes, to cause coagulation also, wax paste to stop bleeding from diploic veins in the skull, we'll study it later. Cyanoacrylic medical glue, yes, it's like modern method. Then biological methods, use of hemostatic sponge, omentum, greater and lesser omentum we can use, usually greater omentum. We put it in the wound, we stitch it together with omentum, and it helps also to stop bleeding. And hemostatic sponge is that substance that contains in itself clotting factors and assist in hemostasis. Okay, so temporary bleeding arrest. It's like, I think, things which you probably have already studied, maybe not. Okay, so finger compression. Certainly you cannot compress anywhere. There are special places for compression of certain vessels. So for the common carotid artery, it is in the point of decussation of projectional line from the middle of the distance between angle of the mandible and mastoid process to the sternoclavicular joint with carotid tubercle of the 6 cervical vertebra. Actually, when we studied anatomy, we said that transverse process of the 6 cervical vertebra is named carotid like it has carotid tubercle, and it is a place of compression of common carotid artery in case of its bleeding. Facial artery, it is at the middle of the inferior margin of the mandible. For superficial temporal artery, it is 1-2 centimeters above the middle of the zygomatic arch. Subclavian artery, in supraclavicular fossa, we have to compress it to the first rib, in the direction to the first rib. Femoral artery, in the point of decussation of projectional line between middle of the inguinal ligament and the medial condyle of the femur with the superior ramus of pubic bone. And certainly, if we compress all the all the previously mentioned arteries, we can use just one finger, like thumb maybe. In case of compression of femoral artery, certainly we have to use several fingers because femoral artery is rather large. So here you can see, yes, place of compression of common carotid artery, yes, then subclavian artery, maxillary artery, superficial temporal artery, brachial artery, you can see it, and axillary artery. So these are points of compression. You will have to study it. We will discuss it when we reach operations on the vessels in our practical classes. So this is method of the temporary hemostasis. If we are talking about final hemostasis or definitive hemostasis, one of the way it is ligation of the vessel in the wound. Ligation of the vessel in the wound. So the goal, the aim of this surgical intervention is to close the lumen of the vessel at the site of damage. Ligation of the vessel in the wound is performed in emergency cases, in case of traumas or gunshot wounds. So here you can see how to do it. I hope it's clear, yes? First, you find the vessel, you apply a clamp onto it, you can use Deschamps needle, yes, which we saw at our practical classes last week, Deschamps needle. We conduct the thread under the vessel and we tie a knot, and that is all. And then we remove the clamp and bleeding stopped. That is ligation of the vessel in the wound. Ligation of the vessel along its course. So the goal is to reduce blood flow to the damaged part of an organ or limb, as well as to temper in one or another area when large blood loss is expected. So usually we ligate the vessel along its now, can you hear me? Yes, okay, fine. So the goal of this ligation is to reduce blood flow to the damaged part of an organ or limb, as well as to temporarily stop blood circulation in one or another area when large blood loss is expected. So indications are impossibility of ligation of the vessel in the wound, risk of exacerbation of infection as a result of manipulations in the wound, the presence of traumatic aneurysm, the need for amputation of the limb in case of anaerobic infection when the application of tourniquet is contraindicated, the risk of erosive bleeding. These are indications. So how to perform it? Ligation of the vessel along its course is an application of ligatures onto the preliminarily exposed vessel. So the first stage, it is an application of proximal ligature, it's one, yes. Then second stage, application of distal ligature, it's two. Then third stage, application of a stitched ligature, so that one that passes through the lumen and that injures, it pieces walls of the vessel 1 centimeter distally from a proximal one or at the boundary between proximal and medial 1/3. And the fourth stage, it is dissection of the vessel between stitched and distal ligatures. That's how you can ligate the vessel along its course. So on the part from where blood comes, you apply 2 ligatures. At the part from where blood goes, you apply only 1 ligature. Dissection of the vessels is required for desympathization of its distal part. Desympathized vessel forms new collaterals faster that increases its chances to save body part of the organ supplied by it. So that's why we do not only ligate but dissect to deprive distal part of the vessel by sympathetic fibers. It will increase speed of formation of collaterals. Ligation of the vessel along its course can cause necrosis of tissues and organs which receive blood from a ligated artery in case of an impossibility of collateral circulation. So which ways of collateral circulation exist? So first, there's a large pre-existing intravascular anastomosis. So those anastomosis which we have already discussed with you, yes, for example, scapular arterial circle in the upper limb, yes. Then intramuscular arteries, so inside the muscle. Periarticular arterial networks. These are, for example, arterial network around the elbow joint, arterial network here you can see around the knee joint in this diagram. Then perivascular bloodstream, vasa vasorum, and newly formed collaterals. But look, large pre-existing intravascular anastomosis, they can provide blood supply, constant blood supply, even in case of an acute thrombosis or in case of a ligation. And newly formed collaterals, it takes time for them to be formed. That's why they work only in case of slow occlusion, as we said, also at our practical classes. So vascular suture. What are the requirements of vascular suture? First of all, it is tightness, hermeticity, because blood vessels contain blood. Blood is tissue, but still it is a liquid tissue, yes. And to prevent leakage of blood, vascular suture should be tight. Then durability or strength. Then prevention of the narrowing of the lumen. For this, we have special tips. We'll discuss it later, yes. Then asepticity, atraumaticity, and prevention of clot formation. For that, suture material shouldn't be in the lumen and in contact with blood, because in case of the suture material of the lumen, in case of any foreign particles in the lumen, clotting factors, they are accumulated here and clot is formed. Stages of vascular suture. First, it is revision of soft tissues, blood vessels, nerves, bones, and primary surgical treatment of wounds. Then mobilization of the vessel. Then preparation of the ends of the vessel for suturing. So vascular clamps are applied to the ends of the vessel to perform temporary hemostasis. Then suturing of the vessel, the fourth. The fifth point, it is control of hemostasis and patency, conductivity of the vessel. So for that, we have to remove the clamps from the vessel to check tightness of the suture, tightness of the seam. So yes, we can ligate, we can stitch the vessel in that way that even we do not leave the lumen of the vessel. And so it will be very tight, very hermetic. But transport function of the vessel will be also impaired, yes? So that's what we have to look to watch after. Conditions for application of vascular suture. So first of all, vascular suture should be applied only in aseptic conditions. If a wound is infected, we should not apply vascular suture in the wound. We should ligate the vessel all along its course, somewhere proximally, yes, for the artery and distally for the vein. Then wide anatomic approach to the vessel injury. Walls of the vessel should be viable, that is, blood and nerve supply of the vessels should be saved. If length of the injury does not exceed 1/3 of artery circumference and diameter of the vessel isn't less than 4 millimeters, lateral suture is applied, so just side suture. I will show you later at the diagram. If length of the injury exceeds 1/3 of artery circumference and diameter of the vessel is less than 4 millimeters, circular suture is applied. Artery should be separated from paravasal tissues and compressed by clamps or ligatures. To increase diameter of anastomosis, ends of the vessel should be dissected at the angle. So here, first of all, you can see this is lateral suture if length of the vessel does not exceed 1/3 of the vessel circumference. Yes, here you can see it. And this is circular suture in case of a complete rupture of the vessel. If wound in the vessel exceeds 1/3 of the circumference of the vessel. So here you can see, yes, look, if, for example, we will try to stitch to connect these two margins, these two ends of the vessel, you should always remember that some part of tissues will be taken by suture, yes, and that will narrow the lumen. That's why to avoid narrowing of the lumen, we use hypotenuse. No, you understand, yes, like there is carotid, and hypotenuse. We make angular cutting, and angular cutting, this hypotenuse is always larger, is always longer than this. And despite the fact that anyway some part of tissues will be taken by suture, we will not narrow the lumen. That is the rule. So then, suture should be applied without a significant tension. Therefore, distance between the ends of altered vessel shouldn't exceed 3 to 4 centimeters. If it is larger, then we should use some transplants. Yes, maybe proper transplants of the same person, or maybe prosthetics even. So to decrease tension in the region of vascular suture, mobilization of artery proximally and distally from the place of injury along 10 centimeters is required, and flexion of the limb in the nearest joint and subsequent immobilization is also used. To apply vascular suture, microsurgical forceps and needle holders are used. Сейчас лекция у меня. А что? Я там принесла положение, положение они отксели и отдали. Так, electromatic needles with non-absorbable suture materials are used 4-0 to 6-0. And yes, we also said about it, yes, at the previous lesson, that in case of vascular suture, we usually use non-absorbable suture material. And suture material should possess thrombo-resistant properties. So they shouldn't help assist in formation of clots. Okay, so here you can see, certainly usually in case of vascular suture, we use continuous suture, because we also said about it, yes, that continuous suture, they are more hermetic, they provide tightness better than interrupted suture. And so here you can see continuous vascular suture. The main, like the classic method of vascular suture was invented by Alexis Carrel. Here you can see his years of life. He's an outstanding surgeon and biologist, and he is Nobel Prize winner in physiology in medicine in 1912. So, and this suture is still named Carrel's suture. It is circular suture. So how to perform it? First of all, we apply 3 interrupted sutures to connect the end of the vessel. Here you can see it. Then we apply continuous suture between first and second interrupted sutures, second and third and first hold the threads. And look, we actually, for this continuous suture, we use ends of the thread which applied the first, second, and third interrupted suture. So this is Carrel's method, which is still used. It's very, like satisfies all the requirements for vascular suture, and it is, yes, very good. There are many other types of vascular sutures. So there are single nodal sutures, but they are not like hermetic. They are not widely used now. There are single metros seams. Yes, we can see it like U-shaped. Yes, there are simple continuous suture, just along the whole circumference goes continuous suture. Then continuous metro suture. There is mechanical seam with special suturing apparatus. Here you can see, yes, simple separate nodal suture, and this one is U-shaped, or metro suture, yes, of Brian and Jeboulet. They also used very many different techniques. Here you can see terminal end-to-end arterioanastomosis by Darans. It's like metro suture, yes. And here you can see anastomosis end to side, terminolateral anastomosis, yes. And so now let's watch the video about the contemporary method of suturing. It is a new technique. It is now widely used. It is parachute technique of the suturing of the vessel.
The parachute technique is a useful technique.
They write that I have unstable internet connection.
The parachute technique is a useful technique for arterial reconstruction and can be applied even to quite small vessels. Here, we present a living donor right lobe transplantation case where the parachute technique is used in the anastomosis of small vessels. Here, we present a living donor right lobe transplantation case where the parachute technique is used in the anastomosis of the donor and recipient right hepatic arteries. The donor artery is first flushed with heparinized saline, then backbleeding is controlled with a microvascular bulldog clamp. The artery is trimmed of the excess neurolymphatic tissue around the adventitia. The recipient's right hepatic artery is selected as suitable for the reconstruction. A vascular clamp is placed on the proximal artery, compressing the tissue around the vessel. Whenever possible, it is a good idea to incorporate tissue around the vessel so as to avoid direct trauma to the artery itself. The artery is then trimmed to an appropriate length. We strive to leave a slight tension on the anastomosis to avoid kinking once the clamps are removed. In this case, the donor and recipient arteries are a good size match. A length of double-armed 7/0 purling suture will be used to parachute the orifices of the two vessels together. The first bite is an in and out suture at the apex of the recipient artery. An out and in bite is then placed at the apex of the donor artery. This process is then repeated along the posterior vessel wall until the posterior walls of both arteries are secured and oriented with a continuous suture. The suture is then rinsed with heparinized saline to reduce friction. Gentle traction is applied to both ends of the suture in a direction perpendicular to the axis of the vessels.
Actually, I turned off my microphone, but can't you see the picture? See the picture? Oh, Himansu sees, so we will continue. Many of them see. Try to do something, please.
A pair of atraumatic vascular forceps is used to provide intermittent countertraction in the direction of the axis of the vessels. This helps distribute tension evenly along the suture and will allow the vessel walls to parachute together. Through this repeated process, the vessel walls are gradually brought together. The anterior vessel wall is then brought together with a continuation of the running suture. This concludes the parachute suture technique.
So, well, for those who couldn't see, I will send you this video, and in the evening you will enjoy it. Okay, so let's continue. So surgeries at the vascular obstruction. First of all, they are divided into exovascular, which are aimed to eliminate the pathology out of the vessel, like if decompression of the celiac trunk, sympathectomy. So if vascular obstruction is caused by a tumor, for example, that is outside of the vessel, certainly we shouldn't do something inside. We should just remove this tumor. And endovascular, which are aimed to eliminate stenosis, narrowing, yes, in the vessel lumen. It is balloon angioplasty, stenting, and so on, yes. And also there is reconstructive surgery, when just if we have vascular obstruction, we take and remove this part of the vessel, and then we reconstruct this canal, vascular canal. So we connect two ends. So here you can see endovascular surgery, that is direct thrombectomy. So if there is an embol, there is a thromb, we just apply two clamps. Between two clamps, we dissect wall of the vessel, we remove this clot, and we stitch. This is direct thrombectomy. Sometimes it is possible, sometimes it is not. And then we perform loop thrombectomy. How does it work? Like we enter through the vessel, through the wall of the vessel with a special instrument that is loop, or maybe it can be also Fogarty catheter. And so first it's like just as a needle, yes? And with that needle, we pass, like it is less traumatic. With that needle, we pass through the clot, and when we reach the end of the clot, we open this loop, or we open this Fogarty catheter, and it expands, it inflates, and then we pull it back, and together with this catheter, the clot also is pulled back. So, okay, now I will show you this. Fogarty catheter was invented in 1961 by Dr. Thomas Fogarty. A very simple device, and like it's widely used. So you see, it inflates at the end, and then we pull it back, and the clot also leaves. Yes. And when we pass through the vessel, through the clot, we do not certainly inflate it first. Okay. And yes, here you can see a technique of thrombectomy with the Fogarty catheter. So we enter, for example, there is a clot somewhere in the common iliac artery. We enter through the femoral artery with a special introducer, yes. We reach the clot, we piece the clot, and we reach the end of it, certainly under the X-ray assistance, maybe ultrasonography assistance, usually X-ray with a contrast agent, yes. And so we reach the end, and then we inflate this Fogarty catheter, and we pull it back, and clot is going with us, with this Fogarty catheter. Yes, very simple and very atraumatic. So certainly it's much less traumatic than if would be entered abdominal cavity, peritoneal cavity, found somewhere common iliac artery, dissected it. Certainly it is a great artery with a great blood flow. Yes, so this is very good surgery for that. And once again, you can see the same thrombectomy with a Fogarty catheter. It is, yes, indirect thrombectomy. There is also stent retriever thrombectomy, another one thrombectomy. Okay, let's try to watch it as well.
This is an animated video of a thrombectomy. So we place a large catheter in the carotid artery within the neck, and through that we advance a small micro wire that goes up through the blood vessels. It comes up to the point of the occlusion where the clot is, and it passes through the occlusion point into the normal vessel beyond it. Over the tiny wire we advance a very small catheter. It passes through the blood clot, and then we take the wire out. We usually inject a little bit of contrast beyond the tip of the catheter to ensure that we're still in a blood vessel, because remember, we can't quite see this on an angiogram. And then we advance the stent retriever, and just by pulling back the catheter, the stent widens and deploys itself in the blood vessel. It engages with the clot and allows some immediate restoration of blood supply. Sometimes we inflate a balloon in the neck to stop blood flowing and washing the clot off, but we pull back the stent, which has now engaged the clot, and it pulls and comes back into the catheter in the neck, and then we remove it altogether from the body. And if at first the clot doesn't come out fully, then we go in again with further passes.
The sense is clear, yes? Like we just use a stent, the stent catches the clot, and again we pull it back with stent. The other type, it is aspiration thrombectomy. Aspiration thrombectomy. This one. In this case, we just, again, insert the wire and we just suck the clot out, yes, by a special aspiration device. Yes, so also it is very simple. So nowadays, with the appearance of special devices, certainly open surgery is gradually substituted by this special luminal surgery, yes? Like small mini invasive surgery, let's say so. And that is good, of course. Rehabilitation is very fast for the patients, is good, but from the surgeons it requires additional skills. Okay, so thrombendarterectomy is another, thrombendarterectomy is another operation. The essence of the operation is to remove the thickened intima along with an atherosclerotic plaque and a blood clot formed above it in the narrowing zone of the artery. So in this case, we do not just remove the clot or the plaque, because plaque is fused with an intima, the internal membrane, internal layer of the vessel. So we dissect the vessel, and with a special instrument, we remove clot together with this thickened intima. This is thumb and arterectomy. So the other, it is reconstructive surgery, bypass surgery. Yes, the essence of the operation is to create, with the help of an aorta vein or prosthesis, an additional path for blood flow to bypass an existing obstacle. With narrowing of the coronary arteries, coronary artery bypass grafting has become widespread. So with narrowing of abdominal aorta and iliac arteries, aortic femoral bypass surgery is performed. And in case of the narrowing of the femoral artery, femoral popliteal bypass is also performed. So, so that is the sense, yes. So somewhere there is, we can see occlusion, yes, and we take maybe aorta grafting, so some vessel from the body of our patient, or maybe some other grafts we take, and we create just anastomosis. Yes, this graft we stitch to the proximal part above the occlusion, and we also stitch it to the distal part below the occlusion, and blood, like we create artificial collateral. Yes, we create artificial collateral. Yes, that is the sense. So angioplasty is a restoration of the patency of the vessel or its integrity with the possible use of aorta, HOMA, and synthetic grafts. So balloon angioplasty first, and stenting. This is restoration of the patency of narrowed or fully obliterated vessels by introducing a special balloon into the narrowing zone and inflating it in the lumen of the vessel. So it is balloon angioplasty. Just we reach the place of obstruction with this balloon. We inflate balloon, we deflate balloon, and we remove balloon. And certainly it's not very efficient, because yes, it will be dilated a little bit, but mainly after the removal of the balloon, it will be constricted again. Usually this balloon angioplasty is also goes together with stenting. So stent is a special mesh tube that creates a frame for the lumen of the vessel and does not give it to contract. So first we inflate balloon. Together with balloon, we apply stent. We deflate balloon, but stent stays. So usually this coronary stenting is very popular nowadays, and it is used widely. It's widely used. So usually balloon angioplasty is complemented by stenting. Okay, transplantation. So aorta transplantation is a transplantation of organs, tissues, or even particular proteins from one part of the body to another in the same person. So it is related not only to the vessel surgery, but to all the surgeries. We will talk about it at the future lectures as well. So aorta means self, it's clear, yes, in Greek. Allotransplantation. Alla means other in Greek. It is a transplantation from a genetically non-identical donor of the same species. So the transplant is called allograft, allogenic transplant, or homograft. So allo or homa, it is actually the same. So if we use transplants, not from ourselves, not from our patients, but from another people, humans, yes? So xenotransplantation, xenos means foreign, or heterologous transplant is a transplantation of living cells, tissues, or organs from one species to another. Such cells, tissues, or organs are called xenografts or xenotransplants. So it means from animals, for example, but like it was widely used in the past. Nowadays it's nearly out, it's not out of use, because rejection reaction in this case is very no, very common. Yes, so usually we don't use it. Okay, so types of aorta transplants. So there are aorta-venous transplants. They are usually formed from superficial veins, like we use greater saphenous vein, superficial veins of the upper limb, basilic and cephalic, yes, external jugular vein. In this case, what we should remember, what we should be aware, aorta-venous grafts should be reversed so that the venous valves do not interfere with blood flow. So if we talk greater saphenous vein, yes, and so this is, here there is distal part, inferior part, here there is superior part, yes, we know that there are valves which allow movement, blood flow only upward, yes, only upward. And if we use it for coronary bypass, we need to blood flow downward, yes, that's why we like, what are we doing? We turn it 90 degrees, yes, we reverse it. That is very important. Okay. Also, we use aorta-arterial transplants. They are used for re-implantation of the fingers, for example, of the hand, and for mammary coronary bypass. The advantage of inserts, these aorta-arterial transplants, is the approximate correspondence of diameters and wall thicknesses of the vessel. So which arteries do we usually use for aorta-arterial transplants? So yes, we use mammary coronary. Mammary artery, it's actually the old name of internal thoracic. So we use internal thoracic. We create anastomosis between internal thoracic artery and one of the coronary arteries where there is obstruction. And it is fine because we know that in the thoracic cage there is a very well-developed network of anastomosis. Like, for example, posterior intercostal arteries, they can give the blood to anterior intercostal arteries, and diaphragm will also not suffer because superior phrenic artery and inferior phrenic artery, they can absolutely substitute function of muscular phrenic artery that goes from the internal thoracic. So yes, and we can use as aorta-arterial transplants radial artery as well, because we know that in the anterior region of the forearm there are 4 neurovascular bundles, and actually they can work for one another. Like, again, we have very well developed network of anastomosis. If we take radial artery, that will be fine. Blood supply of the forearm and the hand won't suffer much. So yes, there's a topic, it is the surgery of aneurysms. Aneurysm is a permanent abnormal blood-filled dilation of the blood vessel. Here you can see aneurysm. So aneurysms can be true, false, and dissecting. So true aneurysm, it is dilation of the vessel wall bounded by all 3 layers of vascular wall. Yes, so you remember in the vessel there is tunica intima, tunica media, and tunica externa. Yes, and if this in the wall of the aneurysm there are all the 3 layers, then it is true aneurysm. False aneurysm or pseudo aneurysm is a dilation of the vessel bounded only by tunica externa, only by tunica adventitia. So it is in case of the injury of tunica intima and tunica media, this is false aneurysm. And dissecting aneurysm, it is actually hematoma that accumulates in tunica media of the aorta. Usually it's more common, it is in the aorta due to the rupture of tunica intima. It is dissecting aneurysm, and it is, yeah, it's very dangerous. So here you can see this is true aneurysm. You can see that all 3 coverings, all 3 layers of the vessel wall, they also form aneurysm. Here you can see false aneurysm when there is a rupture in tunica intima and blood goes outward, yes, like, and in tunica media, in tunica intima, and it is covered only by tunica adventitia. And dissecting aneurysm is very dangerous. Like, there is an injury in tunica intima and blood along the blood, direction of the blood flow, it goes between tunica intima and tunica media, and it like dissects, like separates tunica intima from tunica media and pushes forward, and finally it separates tunica intima from the other layers of the vessel wall completely. So this is dissecting aneurysm. So what are the methods of surgical treatment of aneurysms? So the goal of aneurysm treatment is to isolate the aneurysm from the circulation while ensuring patency of parent artery, like that artery where it was formed, and perforator branches. So there are several methods. There are ligature methods, which are aimed to create conditions for the thrombosis of aneurysm sac. So just ligate aneurysm and wait until it can be like blood inside it will be coagulated, yes? Obliterating methods are aimed to create conditions for the fusion of the walls of aneurysm sac with an opportunity of recanalization. Reconstructive plastic methods save or restore patency of the vessel while exclude aneurysm from the blood flow. So ligature method, so the most ancient, the newest method, the oldest method, it is Antilus method. Antilus method. So what can you see? Yes, as I told you, we just take a part of the vessel where there is an aneurysm and we ligate it proximally and distally from the aneurysm, and even we put inside some gauze and we are waiting when thrombosis takes place. Yes. Sorry, no, sac is dissected, yes, of the aneurysm, and it is packed with gauzes, and to cause benign separation, evacuation of the sac content. So the most common complications of this method, and certainly it's not used nowadays, these are gangrene and compression of nerves. So the other method, it is Filagrius method. So we ligate all the efferent and efferent vessels which come up and leave the aneurysm, and we perform extirpation of the aneurysm. So the most common complication is postoperative bleeding, because you see how many ligatures we should apply. One of them will definitely slip out and it will cause bleeding. Okay, so now we have to watch one more video. Well, you can see, yes, so the main aim of obliterating methods is to exclude the aneurysm from blood flow, and finally it will be obliterated. Maybe it's by itself, like it will be fused to its walls, yes, maybe because we inserted a special wire inside, and so on. Why are these aneurysms so dangerous? Yes, because you studied it on the first year in physics. If there is turbulent blood flow, not laminary, it creates conditions for the formation of clots. So the most common complication of aneurysm, it is thrombosis and also rupture of aneurysm, because like in case of false aneurysm, for example, yes, because walls are weak, walls are thin, and pressure is the same as in the rest part of the vessel, and aneurysm can be also ruptured. That's why we should treat it. So reconstructive methods, Matas method, for example, and aneurysmography. So we just dissect, certainly we apply clamps, yes, to stop the blood flow. We dissect the aneurysm along its course. We find the wall, normal wall of the vessel, and we stitch it. So we again exclude aneurysm from the blood flow. Yes, from the blood flow. Okay. So surgeries at varicose veins of lower limbs. There are many types of surgeries for this. So the first, it is crossectomy, or it is also known as operation of Trajanov-Trendelenburg. So the sense is, what are we doing? It is separation, ligation, and resection of greater saphenous vein and all of its tributaries in subcutaneous fatty tissue at the level of saphenofemoral junction. So we find greater saphenous vein ligated and resected and all of its tributaries. The other way, it is Madelung surgery. So removal of greater saphenous vein along the thigh through the long approach from upper 1/3 of the thigh to the medial condyle of femur, along the leg from the medial condyle to the medial malleolus. So the sense is clear. Yes, why is this varicosis developed? Because in normal cases there are special shunting veins, and in all cases they exist. And usually venous drainage goes from superficial veins to the deep veins, because these special perforating branches, communicant veins, they have valves and they are unidirectional, and they should allow the blood flow only from superficial veins to the deep. But with an age, in case of an increasing of the pressure on the veins of the pelvis, like for example in case of pregnancy, yes, or if for example person works at always he stands, yes, standing work, yes, then it causes formation of varicoses. So these valves, they become weak, they get impaired, and blood flow in the opposite direction to the superficial veins, and walls of superficial veins, they get dilated and they form these varicoses. And that's why we try to decrease blood flow in these veins by different types of surgeries, yes? So Madelung surgery, we remove greater saphenous vein along the thigh through the long approach from the upper 1/3 of the thigh to the medial condyle of femur, or along the leg. So two types of surgeries of Madelung, that's it. So then Narat surgery, it is a removal of greater saphenous vein through numerous short incisions. So we also remove greater saphenous vein. And so by this method, we create conditions for the venous drainage only through the deep veins. The other method, it is Babcock surgery of vein stripping. So this is a special device that is known as vein stripper. So it is a removal of greater saphenous vein along the thigh or leg by means of a vein stripper. So we enter, if we want to remove it along the thigh, yes, we enter somewhere at the region of the medial condyles. We pierce the vein, insert this vein stripper, and we go upward until we reach place of the drainage of greater saphenous vein to the femoral vein. Here we leave. And after that, we pull the vein back to the medial condyle. So we remove the vein. Okay, this is Babcock surgery. Then Coquette and Linton surgery. It is a ligation, we do not remove greater saphenous vein stays, but we remove connections, yes, between superficial and deep veins. So we ligate these communicant veins. In case of coquette surgery, we perform epiphyseal ligation of communicant vein, so above the superficial fascia we ligate them. And in case of Linton surgery, just at a subfacial ligation, we do it below, under the superficial fascia. And so the last type of surgeries, these are surgeries in case of a non-vascular pathology. In which cases? We perform it in case of formation of benign tumors, for example. Like, for example, in gynecology, it's widely used. We have myoma, for example, benign tumor of myometrium. And these myomas, they have very good blood supply. And if we deprive it by blood supply, if we stop blood supply of this myoma, then it won't grow fast, or maybe it will even decrease its size. Yes, certainly it is not a radical surgery. Yes, so we perform embolization for a blockage of the vessel with special substances and devices like liquid sclerosants. So these substances which cause sclerosis, yes, formation of connective tissue inside the vessel lumen, plastic particles, spirals. So how do we do it usually? Also, we do it through the approach in the femoral artery. This wire, by this introducer, we reach a common iliac artery. From the common iliac artery, we go to the internal iliac artery, and then we find uterine artery, and we find, by this catheter, we find a special branch of the uterine artery that supplies particularly this myoma, and we perform embolization. So we inject something that causes embolization. This is vascular surgery in case of a non-vascular pathology. So this was a brief description of all vascular surgeries. At our practical classes, we will discuss everything